Welcome back, everybody, to your next shift. The fluorescent lights are buzzing. You've got your coffee in hand. You're about to check in with your charge nurse, and it looks like just another day until it's not. Today's patient, this is going to be someone you know. This is Jesse, the 24-year-old pharmacy tech that you interact with at least several times a week. He passed out today, right there in the pharmacy. He was down for about 30 seconds. The other pharmacy tech said he woke up a little bit confused, but otherwise okay. He tells you he doesn't have any medical problems. Says he felt a little feverish earlier, but he basically shrugged it off. He was feeling really not bad and came into work. Now he just wants to go back to work. Vitals, all normal. Except he does have a low-grade temp. He has 100.4. Jesse just wants to sign out, get out of the ED, sign out AMA, and go back to work. You want to respect his wishes. You get the gut feeling, that stubborn voice inside that says, not so fast. So let's start with the basics. What is syncope? Syncope is a brief loss of consciousness due to reduced blood flow to the brain. Basically, you're quick to go down, but you're quick to get back up. This is not seizure-like activity. This isn't someone who is on some type of intoxicant. It's not someone who had a stroke. 10 seconds of no perfusion to both cerebral cortexes or the brainstem, and that's lights out, but briefly. And it's common. 1.2 of all ED visits every year. So that equates to about 1.7 million visits annually here in the US. But here's the catch. Only about 10% of all those patients, we find something deadly. Things like a pulmonary embolus, an aortic dissection, a subarachnoid hemorrhage, or a cardiac dysrhythmia. Cardiac syncope, that's one of the ones we lose sleep over. So what is our first move? Airway and breathing. Always, every time. In this case, intact and adequate. Circulation, normal. Cardiac monitor and 12 lead, always, no exceptions. You're going to do a quick neuro exam, make sure there are no obvious deficits, and we're going to check for any subsequent trauma from the fall. Easy, maybe. Simple, never. Because in young patients, like our pharmacy tech, the bad stuff is sneakier. History is key. Was there a prodrome? Did the patient have any lightheadedness, nausea, sweating? Was there any exertion prior to the incident? Did they pass out while they were sitting, driving? A no to the prodrome or a yes to exertional syncope are definitively red flags. Family history? Someone in the family died young, a sudden cardiac death, history of structural heart disease. This is the time to ask, to press, to dig. If you go too fast, the patient will be prone to gloss over a vital clue. Because here's the brutal truth. Cardiac syncope has a 6-month mortality rate over 10%, and the sick ones don't have that written on their forehead. You order the EKG, and there it is. A pattern that's a little odd. Cove-shaped ST segment elevation in leads V1 through V3. And it almost looks like a right bundle branch block, but maybe not quite as wide as it should be. ST elevations in Jesse, but he never had any chest pain. He has no cardiac comorbidities. So what links painless ST elevation, localized to leads V1 through V, a right bundle branch pattern, when syncope is the chief complaint, Brugada syndrome? Named after 2 sibling cardiologist brothers who taught us that sometimes the heart's electrical system is born with a deadly flaw. And the fever noted at triage? Brugada can be insidious, that many people with this syndrome won't even display those characteristic EKG changes all the time. But things like a fever can bring that out, just like it did today. So what are some key points about Brugada syndrome? So first and foremost, it is a channelopathy. There is a defect in the sodium channels of the myocytes. It's genetic. And probably most importantly, it is deadly if missed. Fever, certain medications, and even particular anesthetics can unmask the Brugada syndrome. If Brugada syncope can be a warning sign of sudden cardiac death, and today, the fever that he blew off this morning probably saved his life. So now the plan is crystal clear. He is assuredly not going back to work in the pharmacy. He's getting a cardiology consult. He is going to the electrophysiology lab at some point, and he's going to be getting an ICD, an implantable cardio defibrillator. This is going to keep him alive when his own heart tries to betray him. Essentially, you have just changed the trajectory of a life. Because you listen to your patient and your gut, because you know all syncope gets an EKG, and you knew what you were looking for, we have changed things for Jesse dramatically. Emergency medicine isn't just saving lives in dramatic resuscitations. Sometimes it's quieter. Sometimes it's a soft nudge, a quiet refusal to dismiss a story that doesn't quite add up. It's the courage to dig one layer deeper because you know that underneath the surface, something bigger could be ticking. And when you do that, you don't just save a moment, you have the potential to save decades. You save birthdays, graduations, coffee dates, first jobs, bad days, good days. You save possibility. That's the power you carry. And that's this emergency life. We'll see you on your next shift. Thanks again.